Right, for this presentation, I'm going to do the review for our elimination, inflammation, and mobility exam that we have. Please note that not everything in this review is everything that could be on the test, so make sure that you refer back to the blueprint to make sure that you have covered all of the necessary pieces for the upcoming exam. Okay, the first question has to do with what type of medications are used to treat H. pylori. So, treatment requires eliminating both the bacteria and and reducing stomach acid. So, oftentimes we will see a PPI, a proton pump inhibitor, um, and we use the proton pump inhibitor for the properties that it decreases the acid to allow healing. There's usually two antibiotics that are used, and they're usually like a penicillin type, so like amoxicillin, something like that. And we also use a bismuth, and that helps to protect the lining and kills and helps kill the H. pylori. So it's kind of like a triple therapy. We have the proton pump inhibitor, a cytoprotective drug, and a penicillin type antibiotic. Right. So referring back to some of our diagnostic tests, what diagnostic test is used to evaluate upper gastrointestinal problems, such as bleeding? We usually use an EGD, so that's the camera, right? The camera that goes down the throat, and it allows us the direct visualization of the esophagus, the stomach, and the duodenum to identify any type of bleeding or ulcers, maybe some tumors. So that's usually the diagnostic test, not to be confused with the colonoscopy, which is the camera where we go through the rectum area and we have direct visualization of the lower GI. So we can look at the intestines, we can look at the colon, we can look at the rectum, those areas. Right. What is the medication famotidine used for? So it is a H2 receptor blocker that helps to reduce some of the acid production. We use this for GERD. We use it for PUD, heartburn, stress ulcers. It also helps to prevent GI bleeding in critically ill patients. Okay, chronic PUD has three major complications, and what are they? So it has several different complications. So some of them, the major complications, we would look at hemorrhage, perforation, and gastric outlet obstruction would be our three major complications. Perforation is the most lethal complication. Um, the manifestations of perforation could be sudden and dramatic onset, sudden and severe upper abdominal pain that quickly spreads throughout the abdomen, pain that radiates to the back and the shoulders. The abdomen will appear rigid and board like. The patient might have shallow and rapid respirations, an elevated heart rate, a weak pulse. Bowel sounds are usually absent, and they might have nausea and vomiting. All right, how is Hep C transmitted? So Hep C is transmitted through blood and blood products, needles and syringes, so like IV drug users, and sexual activity with an infected partner, which there's a lower risk associated with that for Hep C. But the most common causes are sharing needles. If a patient had a blood transfusion before 1992, and if you remember from our lecture, I talked about how our baby boomers, we saw more of an influx in that uh, age group, and that is because of blood not being evaluated as well as it is today. They can also get it through contaminated medical equipment, unprotected sex with blood exposure, and mother to baby during birth. Okay, so what nursing intervention should the nurse include in the plan of care for a patient with viral hepatitis? Well, we'd want to promote rest to reduce the metabolic demand on the liver. We're going to give them small, frequent meals. We're going to avoid any type of alcohol or hepatic toxic drugs such as acetaminophen, because you know that's really hard on the liver. That's where it's metabolized. We're going to monitor labs, the AST, the ALT, and the bilirubin. And we're going to encourage hand hygiene, avoid sharing personal items like razors or toothbrushes, and safe sex practices. We might need to give vitamin supplementation, and we're going to have them make sure that, again, we go back to the good personal and environmental hygiene. Right, persons exposed to Hep A through contact or food-borne outbreaks should be given what within 2 weeks of exposure? Well, we'd want to give them the immune globulin. It contains antibodies that help protect against various diseases. Both Hep A vaccine and immunoglobulin are used to prevent Hep A infection after exposure to an infected person. It can be given before and after exposure. We usually give this Hep A vaccine or the immunoglobulin within 14 days of exposure to reduce severity or prevent infection. Remember, this Hep A, this really has to do with if you think about when you're in like a restaurant and they have signs up that healthcare workers must wash their hands before going back to work. And it really is to try to reduce the Hep A transmission because it's usually through food handling. Right. What should you do if the next dose of TPN is not available to give your patient? Because sometimes this does happen. So you'd want to make sure that you hang a D10W until the TPN is ready. The reason we do that is to prevent hypoglycemia because the patient is accustomed to continuously high dextrose from the TPN. So it's very important that in the event that a patient is on TPN and for whatever reason it's not available, that we do give them that D10W so that they do not encounter any type of hypoglycemia. What diagnostic test is used to diagnose UC? So this is one that we would use a colonoscopy. It allows for examining the entire large intestine lumen and sometimes the most distal ileum, double contrast barium enema, small bowel series, transabdominal ultrasound, CT, and MRI are also helpful, but still the colonoscopy provides better visualization and allows for biopsy to diagnose UC. And we can also do occult blood testing. What are the systemic complications of a patient with IBD? So we know that IBD is an inflammatory condition that absolutely can affect other body systems. We can have malabsorption. We can get liver disease. Liver function tests are very important for us to review. The patient can get osteoporosis, so we would want them to do bone density scans every 2 years. They could have skin lesions, eye inflammation, and they're at an increased risk of some type of blood clot, so a thromboembolism. So, what are the most common causes of pancreatitis? Well, most common causes are gallstones and alcohol use. Gallstones because they block the pancreatic duct and cause inflammation, and alcohol use is toxic to pancreatic cells and increases enzyme activation. So, what would be the priority focus of care for a patient with pancreatitis? Pain control, absolutely, pain management. Patient usually has abdominal pain, and it could be very severe due to the enzyme autodigestion. So, we'd want to make the patient NPO to rest the pancreas. Stimulating digestion would worsen the inflammation. So we would give IV fluids, monitor for hypoglycemia, and assess for complications like respiratory distress. But our primary focus would be that pain management. What exercises can you teach a patient who is experiencing stress incontinence? Well, these will be our Kegel exercises. They help to tighten the pelvic floor muscles as if stopping urine flow. The patient would hold it for 5 to 10 seconds and relax for 5 to 10 seconds. They'd repeat this multiple times daily, and this helps to strengthen these muscles and reduces that urine leakage. So, what are the different types of urinary incontinence? Well, we have functional incontinence, which is a loss of urine resulting from cognitive, functional, or environmental factors. We have stress incontinence, which is a sudden increase in intra abdominal pressure causing involuntary passage of urine. It can occur during coughing, laughing, sneezing, or physical activities such as heavy lifting or exercise. We have overflow incontinence, occurs when pressure of urine in the overflow bladder overcomes the sphincter control. We have urge incontinence, often referred to as overactive bladder, occurs randomly when involuntary urination is preceded by urinary urgency. And then we have the reflex incontinence. It's a condition that occurs when no warning or stress precedes the periodic involuntary urination. So, what are signs and symptoms of urinary retention? Well, for acute, which is the total inability to urinate, they'll have abdominal distension, an intense need to urinate, or the feeling that the bladder is full. Patients with acute urinary retention will present with sudden pain, or their vital signs may indicate pain. If somebody has chronic, they might have difficulty urinating, needing to urinate again shortly after urinating, straining to urinate, or weak urine stream. What are some important patient teaching points to avoid constipation? Well, there are many things that we can help a patient with, but we would explain to them that they need to drink plenty of water, eat fiber rich foods such as veggies, um, fruits, whole grains, regular exercise, avoid daily stimulant laxatives, and establish regular bowel habits, and respond promptly uh, to the urge to defecate. So, what are signs and symptoms of a UTI? Well, it could be burning with urination, so they might have painful urination. They might have frequency and urgency of urination. They could have suprapubic pain. They could have abdominal or that back pain. They could have fever. They could have sepsis. They could have cloudy or foul smelling urine. Sometimes they could present with a fever. Remember that the older adults may have cognitive impairment such as confusion or hallucinations with a UTI. So, what is polynephritis and what are the clinical manifestations? Well, polynephritis is an inflammation of the renal, parenchyma, and collecting system, including the renal pelvis. The most common cause is bacterial infection. And like we talked about in class, it could be um, from a UTI that wasn't treated. So manifestations include fever, chills, nausea, vomiting, malaise, and flank pain. They may have dysuria, urgency, and frequency. Urinalysis may show pyuria, bacteremia, and hematuria. So, what are the consequences of immobility? Well, like we talked about in class, immobility affects pretty much every body system. Cardiovascular system, the patient has reduced cardiac capacity, decreased cardiac output. They might have orthostatic hypotension, venous stasis. They could get a deep vein thrombosis. Respiratory, we could have rapid, reduced lung capacity, atelectasis, pooling of the respiratory secretions, musculoskeletal, we can have a reduction in muscle mass and atrophy. They can get contractures of the joints. We could have bone demineralization, integumentary system. We can have skin breakdown, gastrointestinal, reduced paralytic mobility. They can have constipation. The urinary system, we can have renal calculi, um, urinary stasis, and infection. So, like we talked about in class, it can absolutely cause issues with all of the body systems. So what type of exercise can help patients who have chronic neurological diseases? So, usually it will be like a low impact, slow, controlled exercises that help to improve balance, coordination, and mobility. So, some examples could be yoga, tai chi, walking, water aerobics, and stretching programs. What should you do first if you suspect a patient has a bone fracture? Well, the very first action would be to immobilize the limb. This helps to prevent further tissue, nerve, or vessel damage. Then you'd want to make sure that you assess for circulation and pain. What are factors that increase the risk of fractures in our older adults? Well, it can be altered center of gravity, their inability to correct a postural imbalance, decreased fat and muscle to act as tissue shock absorbers, reduced skeletal strength, gait and balance problems, altered vision and hearing, slow reflexes, medication usage, so medications that could potentially cause dizziness, hypotension, and then hazardous, like home hazards. So rugs, poor lighting, and then, of course, if they have a history of falls. Okay, so let's define the concept of mobility. Mobility is the ability to move freely, independently, and safely using muscles, bones, joints, the nervous system, and energy. It includes walking, transferring, bending, and carrying out daily activities. The state or quality of being mobile or movable and includes gross and fine motor movements. So, what are some important patient teaching for older adults regarding methods to decrease falls in the home? Well, let's talk about removing trip hazards, scatter rugs, cords, clutter, improving lighting using night lights, installing grab bars in the bathroom, wearing non slip shoes, using assistive devices correctly, such as canes or walkers, and keep needed items within reach. What are the risk factors for osteoarthritis? Well, they could be age related wear and tear, obesity, which adds stress on the joints, previous joint injuries or repetitive stress, genetics, and occupations involving heavy lifting. So, what are some important patient teaching topics regarding osteoarthritis management? Well, they could be weight loss to help to reduce the joint load, exercise such as walking or swimming to keep those joints mobile. We can do heat therapies, which reduces the stiffness, and cold therapy, which reduces swelling. We can use NSAIDs cautiously. Make sure to explain to the patient to take with food to help with the GI um, con- uh, side effects. Balance rest and activity. So maybe not try to do like everything at once. Try to space it out and give your body time to recover. We can have nutritional therapy. We can have alternative therapies, like I was saying, the hot and cold. So those are all important patient teaching topics regarding osteoarthritis management. Remember, we can also use medications, and many of them are those topical creams as well, capsaicin, um, biofreeze, things like that that kind of help with that arthritic pain. Voltaren, I think, is the other one. So the bad part about these is that they have to be reapplied, but they do offer some relief for patients. All right. So, what are some important pre op patient teaching topics for a patient scheduled for a hip replacement? Well, we would obviously make sure that we review post op restrictions with the patient. We would practice the use of the assistive devices, use an incentive spirometer after surgery, pain management expectations, how we could prevent blood clots, such as early ambulation or using the SCDs. Uh, we'd want them to use an elevated toilet seat, use a shower chair, use pillows between their legs, and keep the hip in a neutral position when walking, sitting, or lying. What should hip replacement patients not do after surgery? So we want to make sure that they don't do anything, any type of movement that could risk that dislocating of the new hip. So no bending past 90 degrees. Use no crossing of their legs, no twisting the hip inward, so like an internal rotation. Cross legs at the knees or ankles. They should not put on their own shoes or socks, and they should not sit in a chair without arms because those allow the patient the ability to lift up with their arms to go from a seated position to a standing position. Patients taking anticoagulation medications are at a greater risk of what? Well, they're a higher risk for bleeding, GI bleeding, nosebleeds, bruising, and internal bleeding. Watch for black stools or any type of prolonged bleeding. So, when should a patient taking Cinnamon contact the healthcare provider? Well, report any uncontrolled movements of the face, eyelids, mouth, tongue, arms, hands or legs, mental changes, palpitations, and difficulty urinating. So, if they have any type of worsening Parkinson's symptoms, uncontrolled those jerky movements, dyskinesia, you've probably all seen this on many of the commercials talking about uh, these type of uncontrolled movements. And that you would need to report that. Any type of severe dizziness or fainting, hallucination or confusion, and of course, if the medication stops working effectively. So, what are side effects of anticholinergic medications? Well, there's several. Dry mouth is the main one. Urinary retention, constipation, blurred vision, confusion, especially in our older adults, and increased heart rate. But dry mouth, we can have patients, we can talk to them about those, like if they had hard candies that they could suck on to kind of help keep the mouth moistened. If you have a patient that is taking that and they're unable to perform activities of daily living, make sure you're performing good oral care and keep that mouth moist. What are important patient teaching regarding anticoagulation therapy? So, to report any signs of bleeding immediately, using soft toothbrushes, electric razors, they should not use a regular straight razor. Avoid injury risk activities. If they're taking warfarin, they need to make sure that they continuously get their labs done to check on the INR. Maintain consistent vitamin K intake, so like leafy greens, and do not take any new medications without checking with your healthcare provider. So, why does the wearing off phenomenon occur in Parkinson's patients? It occurs because the brain has progressively fewer dopamine stores, so medications like Cinnamate don't last as long between doses, and symptoms will return before the next dose. So it is, even though we're at maximal dosing, um, it's still that it is just not taking care of the symptoms for the amount of time between medications. So this is what we call the wearing off phenomenon. Patients with skeletal traction have a greater risk of what? Well, if you remember when we talked about in class, skeletal traction has to do with those pins that go through like from the outside to the inside, holding the bone in place, places the patient at a higher risk of infection, skin breakdown from immobility, constipation, muscle atrophy, and DVT due to limited movement. But of course, because we have that break in the skin, it places them at a higher risk for infection. Right? So, what is compartment syndrome? It's a condition where increased pressure within a muscle compartment restricts blood flow. This can lead to severe pain, tissue death, and permanent damage if untreated. It is considered a surgical emergency. What assessments are important for the nurse to do when compartment syndrome is suspected? Well, you're going to go to your 6 Ps: pain, severe, unrelieved by meds, paresthesia, pallor, paralysis, and pulselessness. Pressure, they'll have a pressure feeling. Report immediately. Do not elevate or apply ice. Like I said, it is a surgical emergency. So, what are signs and symptoms of a fat embolism? That, like I said in class, these are fat embolism often occurs with long bone fractures. I think of like your femur bone, right? It's a big bone. So, signs and symptoms of it could be a sudden respiratory distress, chest pain, confusion or altered mental status, tachypnea, tachycardia, petechiae on the chest, neck, or conjunctiva. This is an emergency. So do not wait on this. This is an emergency. A patient will potentially may not survive. That is the end of the review. Please, like I said before, make sure that you look over the blueprint for exam 4 that I provided, because this review only highlighted some of the things. Make sure that you review any type of medications or diagnostic labs, any important patient teaching. And as always, if you have any questions, please let me know.